disease and which population group does it affect the most. So it is a progressive and irreversible. It is a kind of progressive and irreversible neurodegenerative disorder. So what do we understand by progressive and irreversible neurodegenerative disorder? That it get worsened year after year and it can not be reversed by any kind of medication or therapy or surgical or conservative treatment. The main reason why this Alzheimer's disease occurs is the accumulation of amyloid plaques and amyloid is a part of brain, and the deposition or the accumulation of plaques in the amyloid is known as amyloid plaque and neurofibrillary tangles. Accumulation of amyloid plaques and neurofibrillary tangles in the brain is the main reason why this neurodegenerative disorder happened. It leads to progressive loss of neurons and synapses. It is the progressive loss of neurons and synapses. It mainly occurs with aging, and the patient of Alzheimer's disease have a basic clinical feature of progressive memory impairment. It is a progressive kind because once it starts, once the amyloid plaques and neurofibrillary tangles are accumulated in brain, then the memory of the patient declines day by day. Just like he will not remember what happened 2-3 years ago, after that 1 year, after that 6 months, after that 1 month, after that 1 week. So the memory capacity or the time span reduces substantially, which also impairs daily function. And cognition. So this so the patient with 65 to 75, 75 to 85 and 85 to infinite or above than 85 have different epidemiologies of having the Alzheimer's disease, such as 65 to 75 have a 3% chance, 75 to 85 has a 15%, and 85 to above have a 25% chance of occurrence of 35% chance of occurrence of Alzheimer's disease. The main gender that is affected by the Alzheimer's disease are women. I only remember few diseases that occurs to women, and this is one of them. Okay, so this is one of the diseases that occurs to women, and I have a ratio of 2:1. So these are the few diseases that occurs to women, not because they are prone to it, but because they surpasses these age limits. So it's more of a age factor and a living factor, and majority of the men have lesser lifespan than the women, so they are more prone to having the Alzheimer's disease due to their longer lifespan. In India, around 5.3 million, which is 53 lakhs cases are there of Alzheimer's disease. The risk factor. So as we have discussed in this video, you already know that there are many risk factors also. Many, not we can say many, but the main risk factors are basically is age. The main risk factor is age. Second risk factor we have already discussed, the gender of the patient. Female are more prone to it. The third is genetics. So as we all know that they are the non-modifiable risk factor. Not the non-modifiable risk, it is said to be the non-modifiable risk factor because you can't change the gender of the patient, you can't delay the aging of the patient, and also you can't change the genetics factor of the patient. The genes that are dependent for it are APP gene. APP stands for amyloid precursor protein. Amyloid precursor protein Down syndrome patient that have the trisomy 21 gene and apolipoprotein. So these are the three genetics factors which are the non-modifiable risk factors, including the amyloid precursor protein, Down syndrome and apolipoprotein. Talking about the modifiable risk factors, RF. So the modifiable risk factors are basically smoking, hypertension, in late stages people used to smoke a lot and also have some hypertensive issues, due to which these risk factors promote a lot in having the Alzheimer's disease. There is also diabetes, depression, having antisocial behavior, and recently in 2022 new study found that the patient also more prone to Alzheimer's disease due to air pollution. So these are some modifiable risk factors which a person can avoid in their lifetime as much as they can to prevent this progressive neurodegenerative disorder. Now we will discuss which part of brain is affected according to their stages. So brain regions that are affected by the Alzheimer's disease can be stepped into stage 1 and stage 2. The stage 1 and the stage 2 basically altered the transcentorhinal ट्रांससेंटोर्नल, ठीक है, ट्रांससेंटोर्नल पार्ट, that is the combination of basically two parts, which is the hippocampus and entorhinal. So the transentorhinal combines the entorhinal and the hippocampus, and in this stage the memory encoding fails. So the patient in the stage 1 and 2 fails to memory encoding, and he can't even recall the recent memory. So we can say a recent memory loss is seen as a symptom of stage 1 and 2, which is the transentorhinal, that includes the entorhinal and hippocampus. Now talking about the stage 3 and 4. So we basically have three parts of the brain that is affected, which is hippocampus, that also affected in the stage 1 and 2, amygdala, and the basal forebrain. So these are the three parts of the brain that are affected. Hippocampus can also be seen in the stage 1 and 2, but the amygdala and the basal forebrain are also affected in the stage 3 and 4. That leads to memory impairment, because the basal forebrain is a major source of acetylcholine. So a basal forebrain is a major source of acetylcholine, and the loss of acetylcholine leads to the cholinergic deficit, leads to cholinergic deficit, that in turn cause memory impairment. You can also see some mood changes or mood swingings when the stage 3 and 4 occurs. So the mood changes and memory impairment caused due to the lack of acetylcholine, which is the major source of acetylcholine producing to the cortex via the basal forebrain, leading to the deficit of the cholinergic receptor, because the cholinergic receptor bind with the acetylcholine. So the cholinergic receptor will be in deficit due to the lack of production of acetylcholine, as the stage 3 and 4 damages the basal forebrain and affect the basal forebrain. So there will be a memory impairment and the mood swinging of the patient. So As we can see, the transit hormonal combine to form interhormonal with hippocampus, such that stage 3 and 4 also have an limbic involvement, limbic system involvement, while now the next stage, that is 5 6. So stage 5 6 is the isocortical. Iso mean one, cortical mean there are the cortical or the associative cortex are involved in it. So the patient have association of parietal area, the temporal area, and the frontal area. Okay, so the parietal cortex, temporal cortex, and the frontal cortex are affected. As we all know, the parietal, if the parietal cortex is affected, the patient have a apraxia and visuospatial. We already discussed the apraxia and visuospatial in the earlier lectures, so I am not going to waste any kind of time explaining what are those. While the temporal cortex affected, the causes the aphasia, and the frontal involve some executive functions along with behavior. So these are some of the stages according to the brain regions that are affected sequentially, and this anatomical progression are also known as Bragg staging. So the Bragg staging have 6 stages consisting of 1 to 2, 3 to 4, and 5 to 6. So the primary stages, we got the memory loss. Changing from the memory loss, there is a cholinergic deficit. After that, the apraxia, aphasia, and some executive function along with behaviors are being compromised in the Alzheimer's disease. Now we are going deep into the neurotransmitter which we have talked about, the acetylcholine, which is the most important neurotransmitter that is responsible for the Alzheimer's disease symptoms. So the first is acetylcholine. acetylcholine is essential for memory consolidation. And it also provides the cholinergic input to entire cortex. So that's why the acetylcholine is the main neuroreceptor responsible for the Alzheimer's disease. The second one is glutamate, which is less important, as the glutamate is over, the term we say basically is excitotoxicity. This excitotoxicity happens when the NMDA receptors are overactivated. NMDA receptors का overactivation. Okay, so the NMDA receptors are overactivated. That leads to the excitotoxicity of glutamate, which leads to the neuronal death. So the third, moving on, the third neurotransmitter, we have the norepinephrine. The norepinephrine cause depression when the patient have the degeneration of locus coeruleus. So the patient have a depression, and it mainly occurs due to the degeneration of locus coeruleus. So the norepinephrine then we have dopamine, which is basically come way after the stages of the Alzheimer's disease. For example, the Alzheimer's disease has started, so it will come after the dopamine is affected after, I think, 15 to 20 years after the Alzheimer's disease. So it is spared early, unlike Parkinson, which have the dopamine deficit causing the Parkinson disease. So the fifth we have is serotonin. Serotonin cause sleep disturbance. Sleep disturbance. The mechanism or the part that is affected is the Ralph nuclei, which causes the sleep disturbance due to the serotonin imbalance. We don't know much about the Alzheimer's disease so far, but it has some theory that why it occurs and how its pathophysiology basically works. So the most accepted theory is the amyloid cascade hypothesis. This is the most accepted theory and the reason that Alzheimer's disease is caused. All the reasons that I have told are the contributing factor and the risk factor. Some are the modifiable factor and some are the non-modifiable factor. But we exactly don't know how the pathophysiology of Alzheimer's disease basically works. So the most accepted theory says us about the normal and the Alzheimer's patient that a normal patient have also the APP, which is the amyloid precursor protein, that is converted into alpha secretase and gamma secretase into non-amyloidogenic fragments which are basically harmless fragments converted by alpha and gamma secretase. But in a patient with Alzheimer's disease or Alzheimer's disease patient, the APP breaks the amyloid precursor proteins are breaked into amyloid-β 42, which is a sticky type of characteristic. Then this amyloid-β 42 turns into a monomer, that is the amyloid-β 42 monomer. This monomer is then break into oligomer, then it break into fibrils, then it break into plaques. Then this fibrils causes basically a plaques. So the oligomers are one of the neurotoxic compounds. They are neurotoxic until and unless they are soluble. If they are soluble, they are the most neurotoxic compound. These plaques then surrounded by a neuritis, dystrophic neuritis, that leads to the neuroinflammation. We can't get into each of these steps that I am telling, but it's the creamy layer that you got. There are also many other researchers. This is the most trusted hypothesis and the one that is most accepted among all the doctors and researchers. So they are basically not this simple but more briefly explained. So we have to learn only the creamy layer, that we are not getting into research about the Alzheimer's disease or anything else like that. So these plaques causes the neuroinflammation that leads to tau phosphorylation, which in turn causes neurofibrillary tangles. So these neurofibrillary tangles then started to synaptic losses due to the neuron death, then brain atrophy, then the hippocampus is affected, then the entorhinal is affected, then the association cortices are affected, and all these symptoms lead to a patient of Alzheimer's disease having said to be a clinical dementia. What is said to be clinical dementia? Patient who don't remember anything. Okay, so as we are getting deep into it, we understand more thing, and after this topic I think we will start from the dementia itself. So बहुत खराब टॉफी है। ये इमली वाली टॉफी खाई थी, इमली वाली अच्छी रहती है पर पढ़ाते टाइम नहीं तो चला रहे हैं। हमने न्यूरोफिब्रिलरी टैंगल्स सब समझ लिया है। इसके बाद हम ये समझेंगे, ये हाइपोथेसिस सबसे एक्सेप्टेड और सबसे कंप्लीटेड हाइपोथेसिस है। तो इसके बाद हम ये समझेंगे कि अगर हम इसी न्यूरोफिब्रिलरी टैंगल्स को, क्योंकि मैंने आपको बताया कि डेप्थ में चलते हैं, एज वी ऑल नो दीज आर ओनली द क्रीमी लेयर्स दैट वी आर studying. So the neurofibrillary triangles can also be break into Brach staging. What does the Brach staging said about this? It also have stage 6. So we are discussing about the stage 1 and 2, and we already know what does it involve and what does it not involve. So I don't think that you need to know about the neurofibrillary triangles Brach staging, because it basically is the same as the Alzheimer's Brach staging, as the stage 1 stage 2 called the interhornal cortex along with hippocampus. As we all know, the interhornal cortex and the hippocampus lead to the memory loss. The second staging we got basically involved the limbic system. We have already taught it, the limbic system. So this causes a kind of condition of dementia, we can say mild dementia or moderate, mild to moderate we can say. And the staging five to six, which involve the association and the neocortex, and it is widely spread, causes loss of memory or severe dementia. You got it? Now as we all know, that the amyloid accumulation in brain or the amyloid plaques accumulation in brain with the neurofibrillary tangles causes the Alzheimer's disease, having categorized into some of the clinical features stages. We already told you that how it occurs, but according to the clinical stages, if we have to, let's dive into the clinical features. I don't want to teach it, but I will, because I'm a psychopath, so I will teach it. I literally don't want to teach the stages and all the clinical stages. These are the clinical stages which are seen. In earlier we discussed about the brain regions that are affected according to the Brach staging. So this will be the clinical features staging. So first, the patient have the amyloid plaque accumulation along with the neurofibrillary tangles causing the deficit in the acetylcholine, leading to the cholinergic receptor impairment, causing different symptoms. So the patient with mild, we will complete this in this complete session. So we have the MCI, that is mild cognitive impairment. So we'll discuss it one by one, and I am only going to take this board itself to cover all the clinical features, because there are a lot. There is the mild staging, there is the mild when the disease is diagnosis, there is a moderate, then there is a severe part. So the mild cognitive impairment leads to memory complaint of the patient and the objective memory of the patient. Sometimes the patient comes with a complaint of memory and memory objectives. So these are the two complaints patient come with, having the mild cognitive impairment. So these are the two cognitive impairment that can be seen in a patient with mild cognitive impairment. When the disease is diagnosed, we will say it is mild Alzheimer's disease, and the patient complains of recent memory loss, aphasia not in the severe type, but it is an acute type. Basically, not we can say the aphasia word, because it is also a mild stage, so we can say anomia, not the aphasia. We have already discussed the aphasia, anomia and everything else. You can see it. Anomia is the disorder when a person fail to choose the words that he want to speak. So that is the anomia. So the aphasia is the complete language disorder. We have already teased it. So in mild Alzheimer's disease, there is recent memory loss along with anomia and some executive functions such as planning and judgment are affected. Got it? So the recent memory loss, anomia, planning and judgment are affected. So we can say the recent memory loss, such as the memory objective, the anomia, the language part, and the executive function, which is the planning and the judgment, are basically affected in the mild stage of the Alzheimer's disease. Now moving on to the moderate one. Moderate Alzheimer's disease. The patient is said to be in moderate Alzheimer's disease when the patient cannot learn new information. You got it? When the patient can't be able to learn the new information and his or her remote memory is also impaired. So remote memory will be impaired in the moderate Alzheimer's disease, along with all these symptoms also, because we are moving it to moderate Alzheimer's disease. So there is always the earlier symptoms that are present along with these 3 to 4 symptoms that I am going to tell. The first symptom is the person cannot learn any new information, and the remote memory also have the impairment, along with the patient have a spatial impairment and language impairment. So the language impairment is basically a paraphrasia one. So I can write paraphrasia here. Paraphrasia. The paraphrasia one. The patient is fluent but the speech is empty. That is basically a paraphrasia one. So fluent but empty speech with no learning of new information and impairment of remote memory along with the visuospatial impairment. The visuospatial impairment is also known as the dressing apraxia, because the person can't be able to dress him or herself properly. That comes under the moderate Alzheimer's disease. Now we are going to talk about the last one, that is the severe Alzheimer's disease, in which the patient have minimum meaningful communication. So as we all see in the movie, the patient with this type of severe Alzheimer's disease has a very real story about his or her partner. At the end of the story, he tells his caretaker about all those things that his /her lovers are enjoying and this and that. So there are very minimum meaningful communication. There is also rigidity, dysphagia. Sometimes this dysphagia also lead to the intubation of the patient, and also seizures can be seen in the patient. In the severe Alzheimer's disease, the patient also have the incontinence of bladder and bowel, and last, the death of the patient mostly occur due to aspiration or pneumonia. So this is the clinical feature staging that involve the mild cognitive impairment. The mild cognitive impairment can also be seen in the CT and the MRI, which help to detect the disease very early. So the patient should train for it. So as we all see that there's an interesting fact that the amount of nerve that are supplied to our lower limb are basically lesser than the amount of nerve that are supplied even to our two fingers and even our thumb. If we are talking about thumb, the entire thumb get a nerve supply. So the patient with Alzheimer's disease should have a kind of, in terms of a non-modifiable risk factor, if I can say, some type of exercises that a patient can do if he is getting older and older and have a memory impairment, you can also see. So you can learn different tricks of hand, such as this and this essay, like this. So you can see the techniques of the movement. So these techniques used are not proven to basically prevent the Alzheimer's disease, but it can slower the rate, because the hand movement are basically the one that gets the most nerve supply among all the body parts. So learning new hand movements leads to the development of new brain cell and synapses in your brain, which in turns prevent we can't specifically say it can prevent 100%, but it will slow the progression of the Alzheimer's disease. So a patient with this type of impairment, memory impairment of any other type of impairment, if you are seeing it in an early stage, try to show him or her some hand tricks, such as if this thumb is up, so this finger is down. If this thumb is up, this finger is down. There are different many types of hand exercises that are there, which improve the cognitive impairment in the patient, and also the brain activity of the patient are also increased. Even I can perform this type of activity, like this thumb is up, then this thumb is down, this one is up, this thumb. So I am not able to do all this type of things, but I will soonly train myself for it, not the patient, because it is very important. As a patient grow older and older, and the progression of the disease is much faster than any other diseases seen. So we have completed the clinical stages, which is basically of 4 stages. We have the mild cognitive impairment, the mild Alzheimer's disease, then the moderate Alzheimer's disease, then the severe Alzheimer's disease. So in the severe, we already see the reason of the death is basically not the memory or the other one, but it's basically the aspiration or the pneumonia. So the aspiration and the pneumonia one are basically a one thing, because aspirating pneumonia is a disease, and it is basically occur by when a person suffer from some kind of infection or any kind of thing. So it's basically a septic type of disease, a septic type of illness. We already discussed about the memory, so I will not deep down into memories, discussing what kind of memories, such as episodic, semantic, and short term, long term. So I will not discuss about it, because it will lead the topic to a deviated path, or the videos are much more longer than before. The language we have already discussed, the aphasia, the mutism, the anomia. We have already discussed the visuospatial. Visuospatial is compared in which lobe? I think the parietal lobe. We have covered the parietal lobe has the visuospatial one. Okay, so these kind of disease are basically diagnosed from month to year, take already month to year. So you must identify the exact diagnosis of the disease, the Alzheimer's disease. Now we are going to discuss about the medical management. As all the other management will not be as useful as yours. For example, cholinesterase inhibitors should be given to a patient. First of all, if some patient is suffering from dementia. Second is BPSD, which is behavior and psychological symptomatic disorder. So behavior, got it? So they are also be managed, such as exercise, caregiver education, reminiscence therapy, and structural daily routine. So structural daily routine, a caregiver, and the reminiscence therapy along with some exercise. So these are some of the behavior and psychological symptoms that should be covered under the medical management. Under the they are the non-medical management, but they are one of the most important management that you can give to a patient having the Alzheimer's disease, because the patient usually have the not a daily routine, not a caregiver, not doing any exercise, not doing any kind of reminiscence therapy. So the patient usually fall into depression and anxiety also. So you have to pull him or her away from the depression and the loneliness they got. Sometimes these loneliness are so worse day by day that they got sleep disturbance also. So the sleep disturbance is basically caused by the serotonin. So the melatonin and other things should also be taken in mind, not the serotonin, the melatonin. Okay, the melatonin. The melatonin is produced when our skin get outside, when we get outside and we get exposed to sun. So there is a melanin formation. So these are some of the things that can be done. The next we are going to end our lecture very soon is the physiotherapy management. What as a physiotherapist you can do to manage the Alzheimer's disease, because you can manage it, you can't prevent it, you can delay it for some years. If the disease that are going, if the progression is going at a rate of 50%, 60%, then you can reduce the progression by 5 to 10% with the help of physiotherapy. So it is a huge gap when it comes to counting years. For example, a patient having the Alzheimer's disease at starting at about 60 years of age, and then you tell the patient that the management of the physiotherapy can be done to prevent it. So the symptoms, the severe Alzheimer's should take about 20 years. It's an average, vary from person to person, it's an average, 20 years. So it can be reduced up to the severity can't come up to like 24 years after 25 years. So you are putting 25 to 30% of extra time to a patient having the Alzheimer's disease. You can't manage it all, but you can slow it down a bit. First is the aerobic exercise. First is the aerobic exercise. The frequency, why I am she. The frequency should be 3 to 5 times a week. What I am doing, I can't even understand. 3 to 5 times a week. The frequency should be 3 to 5 times a week. The intensity should be moderate. The type of exercise that you will choose is this: walking, cycling, or dancing, or some type of other Zumba training or like that, but the intensity should be the moderate intensity. These type of exercises improve the cognition and activities of daily life in Alzheimer's disease, and it is the evidence exercises. So we are not here talking about some crap things like this and that. Only the things that in all of the lectures, the things that I have taught it are taken from some kind of book or any type of medical research journal or guide. So they are proven method. So the evidence based in basically (2015) by Cochrane. It tells us the exercise improves the cognition and activities of daily life in dementia, and the fit thing, the fit scale trial also shows that the 6-month aerobic exercise improves executive function, improves cognitive or executive functions. So there is a study in 2015 by Cochrane. So it also protect, and we can say also the hippocampal protection is also done with the help of aerobic exercise. So this is the first thing about the physiotherapy management. The next thing will be resistant training. It improves the muscle strength, which helps in maintaining the balance and prevent the patient from falling. There is a trial named as FIST trial also done that shows strength training or resistant training increase memory, So the FIST trial tells us that the resistant training improved memory. The frequency of the workout should be 2 to 3 times per week. The intensity should be moderate, and the repetition in which the resistance training should be done should be 10 to 15 reps. not less, not more. So the resisting training can also be done in this patient. So the cognitive or the dual task training should also be done in case of Alzheimer's disease, because the cognition is severely affected along with motor task, and the gait deteriorated when the patient thinks simultaneously while walking or talking. The training you should be doing is motor plus cognitive. The motor training as well as the cognitive training should be done simultaneously, such as you can do the aerobic exercise and give him or her some kind of quiz or some kind of things to do, like counting backwards to 20, such as counting backwards. Depending upon the stages of the patient, you can also divide and checks where the patient is having difficulty or not. For example, the patient walk holding tray. So these things improve the cognitive ability, and evidence shows it also improves the gait and the cognition both by itself. The next thing you can do for basically balance and cognition, if the patient is male, as you all know, the Alzheimer's disease mostly occur to women, but if the patient is male, he is much more interested in video games, because the video games requires physical plus cognitive engagement. Physical plus cognitive engagement. You have to see thing there and you have to move here and there from a remote controller or from the keyboard or from the VR. So the cognition and other things are also, balance and cognition are also maintained while playing video games. And there are many evidence shows an improvement of motor and cognition while multitasking. The motor and cognition have improved, and while video gaming, the balance is improved significantly in many patients. You are not the first year student, so I will basically divide it into stages. If some patient have mild, moderate or severe Alzheimer's disease, so what you have to do and what you do not have to do. But it is not worth the time that you have given here about all the small details. For example, if I can tell you orally, if someone has a mild Alzheimer's disease, you can do the aerobic exercises, resistance training, balance training, caregiving education, nothing else. If the patient have a moderate Alzheimer's disease, he should have a simple and repetitive exercises, ADL training, transfer training and sensory stimulation, nothing else. If the patient has severe Alzheimer's disease, the patient have passive range of motion. You have to perform the passive range of motion, prevent contracture, respiratory physiotherapy, positioning, and some gentle movement along with the sensory stimulation. Got it? So these are the basic things that the physiotherapy management does to an Alzheimer's disease, and the physiotherapist should have some kind of CST along with reminiscence therapy. I don't think we have discussed the CST and reminiscence therapy. The patient have a CST is basically means the cognitive stimulation therapy. Cognitive stimulation therapy. This therapy basically includes group based activities, games, puzzles, as well as some discussions. So you have also be taking care of these type of things. These are the basic thing. No one hires you for the CST, cognitive simulation therapy. Come to my patient, I want to grouply discuss with you something, I will pay you 1000 rupees for it and this and that. No one will ever hire you for it. Everyone will hire according to the stages and according to the condition or the cognitive or the motor impairment or the patient with sensory lack of sensory stimulation. So the patient will hire you for this, but you can give an extra pointer him for the cognition stimulation therapy, first of all. Second of all, you can give patient reminiscent therapy. Reminiscent therapy basically is discussing past event, photo, music, and his/her likings. ठीक है, discussing past events, photos, and his and her likings. So these are the 2+ pointers that you get when doing a physiotherapy to a patient. So you can see an immense amount of motivation, connectivity, and communication of the patient to you will be much more better if you do these two type of things. What are the red flags while doing a physiotherapy? If the patient has sudden deterioration of cognition, suddenly he or she have low cognitive ability at one time of a day, suddenly the patient fall with a head injury, or the patient have seizure, or the patient have the expiration sign. For example, while feeding, the patient coughs very much, fever, aspiration, pneumonia, delirium and confusion, fever, respiratory distress, and many other things. So these are the red flags in patient that you have to find and prevent the patient from doing it. from doing physiotherapy. Our next topic is dementia, and we will start it right away. Okay, thank you.